So, welcome to this audio podcast, and in this series, the Storm Focus v.3. This is part of another Storm Robotics production, a Storm Robotics Vendip, and this audio podcast will be in and around immunology antigen presentation. So, in line with this as well, this audio podcast will be linked to observing chemokine and chemokine receptor expression in acute renal allograft rejection, or AAR, and in context to some retrospective works as well. Renal in context of organ transplantation, in context of renal transplantation, chronic kidney disease, or CKD, is not by any means the most common cause of is not the most common cause of death or disability. In Britain, while 250,000 people die each year owing to cardiovascular health and hematological sort of conditions, and blood vessel diseases, and more than 150,000 from cancer. 700,000 go into chronic kidney disease, or into different severities that are aligned to chronic kidney disease. Sort of retrospectively, 25,000 Britons and 200,000 Americans receive treatment, or had received treatment, or forms of treatment aligned to chronic kidney disease, and each year the numbers increase. Renal failure or chronic kidney disease becomes more evident with increasing age, although at the same time chronic kidney disease does not discriminate in context of age, in context of age, since adults and pediatrics or the young can fall into chronic kidney disease. And so thus, of the 700,000 people going into chronic kidney disease, or who have gone into chronic kidney disease, 2,000 are over, or had been over 80 years of age, and 5,000 are over 50 years of age. And there's works going back to the mid-90s, works by a physician, Stuart Cameron, in the mid-90s, who has highlighted works in and around sort of the basis around chronic kidney disease. Organ transplantation has a long history, generally a long history, beginning with the skin autografting in India during the 6th century BCE. This procedure entered Western medicine during the early Renaissance, and is described in text on the restoration of nose, lips, and ears by Gaspare Tagliacozzi from between 1545 and 1599. In 1906, Mathieu Jaboulay carried out one of the first attempts in a line to human renal transplantation, human renal transplantation. At the time, Jaboulay used pig and goat kidneys anastomized to blood vessels of the arm of patients with chronic kidney disease, which functioned for approximately 1 hour. And in 1911, Hammond and Sutton of Philadelphia performed the first human to human renal transplant with transient success. It was Alexis Carrel Jaboulay's, one of Jaboulay's researchers at the time, improved the sort of methodologies in and around vascular anastomoses, and introduced cooling as a method of organ preservation in his work in Chicago. Later, moving onto the Rockefeller Institute in New York, Carrel found that he could successfully autograft dog kidneys. However, unfortunately, allografts invariably failed. The findings suggested that technical factors could not have explained the failure. Carrel suggested Alexis Carrel suggested that the principle of immunity might have explained some of the observation. It was in 1942 Thomas Gibson and Peter Medwall published early experience with skin allografts in the treatment of burns sustained by aviators in World War II. Gibson and Medwall noted that the second set of grafts from donor is destroyed much faster than the first, and the results of Medwall's careful animal experiments later were developed into the immunological concept of self and non-self. The first wholly successful human transplant took place on December 23rd, 1954, in Boston, Massachusetts, and surgeon Joseph Murray performed a renal transplant, kidney transplant between identical brothers. While this and subsequent twin transplants did little to solve the problem of rejection, those procedures contributed to proving the value of the procedure and to the solution of many technical and some aspects in and around early scientific premise and basis around transplantation. In 1963, at least in the early 60s, the introduction of immunosuppression agent referred to as azathioprine and a steroid combination therapy produced encouraging results and became the mainstay of immunosuppression until the introduction of an immunosuppression agent referred to as cyclosporine in 1983. Cyclosporine in turn substantially improved outcomes of cadaveric renal transplants, and further innovations include anti-T cell antibodies, both monoclonal and polyclonal, and other agents, including, for example, tacrolimus, mycophenolate, and sirolimus later. And today, renal transplantation is perhaps one of the preferred modalities in context of renal replacement therapy for most patients diagnosed or aligned to aligned to end stage renal disease or end stage kidney disease, or aligned to chronic kidney disease or CKD. And despite the escalating success of renal transplantation, acute rejection and chronic allograft nephropathy, for example, still linger and still permit to be a major issue, or can be a major problem, since the majority of transplants are formed since the bulk of transplants are historically had been organized between a sort of genetic, where there's a genetic basis between identical donors. At the same time, it's in between the mid 1970s and 80s and onwards, the profession known as nephrology, in at least in this context, had to consider more so the immunological consequence of the recipient to donor allograft. In general, the immune response has evolved to establish foreign antigen and permits an immune response. Both cellular, so for example, lymphocyte-mediated and humoral antibody-mediated mechanisms are involved. However, under defined circumstances, a state of immunological tolerance develops, which permits sort of long-term and sort of a purposeful basis aligned to transplantation. And there's works by Haldeman and Goral from 2000, in the early 2000s, who have talked who have highlighted works in and around human renal transplantation and some aspects around transplant immunobiology as well. Transplant immunity results after exposure of a recipient to different histocompatibility antigens, and these transplantation antigens have been assembled as major. So, for example, human leukocyte antigen and ABO blood groups, and aligned to minor histocompatibility antigens, although the latter have been acknowledged in murine-based laboratory models and other animals. However, more in around the scientific basis in context of tissue typing, etc., was not known until again late 70s, between late 70s and 80s. Human leukocyte antigens are controlled by a succession of genes on chromosome 6, referred to as again the major histocompatibility complex, or MHC. the genes have been categorized into major identifications. So HLA, into major identification. HLA A and HLA B are examples of class 1 genes, and HLA-DR and HLA-DQ represent class 2 genes. The genes are highly polymorphic, and for instance, HLA-A has more than 20 alleles, and HLA-B has more than 50 alleles. Therefore, it is highly unlikely that two unrelated persons can have the same HLA type. Both HLA class 1 and class 2 alloantigens are capable of inducing transplant immunity or immunity at humoral antibody and cellular T lymphocyte immune levels. ABO incompatibility is important only in antibody-mediated injury or antibody-mediated injury of the allograft. And since transplant immunity can lead to acute allograft rejection or rejection, it seems best that a patient and donor are matched for histocompatibility antigens. Although this is possible for genetically identical twins, which are referred to as syngenic grafts, and to a lesser extent between HLA and ABO identical siblings, the vast majority of transplant come from the vast majority of transplants, at least on some basis, come from incompatible, unrelated, or cadaveric donors. Immunosuppressive drugs are given to control transplant immunity so that rejection can be prevented or controlled, and the recipient develops a long-term acceptance or tolerance of the transplant. Rejection can be mediated by antibody lymphocytes or both, and can manifest itself in different ways. Hyperacute rejection, so for example during early transplant duration, acute rejection may occur or could occur at any time, and chronic rejection is referred to at least in literature, where it's a slowly developing process causing a progressive decline in allograft function. So in context of what's referred to as hyperacute rejection, vascularized organs, so for example, and especially renal and the heart, the kidneys and the heart, are at risk for hyperacute rejection if the patient has preformed donor-specific antibodies. So in this context, IgG or IgM. The humoral presensitization or alloimmune immunization may be caused by previous transplantation, blood transfusions, and or pregnancy. The initial target of donor-specific alloantibodies is an antigen on the vascular endothelium of the transplant organ. The most common target antigens are HLA class 1, ABO, but other less well-defined antigens have also been considered. HLA class 2 antigens seem less relevant in hyperacute rejection episodes because they are not strongly expressed on the vascular endothelium. Following antibodies interaction, complement activation. Activation occurs relating or resulting in endothelial injury. This involves binding and activation of C1q, C1q, C1q in context of the immunological basis, which requires at least two complement fixing sites on the antigen antibody complex, and this requires a close proximity between antigens, and no complement activation will occur if the antigen density is too low on a cell on the cell exterior. Activation of the complement cascade subsequently leads to the release of various inflammatory mediators and the initiation of the coagulation and fibrinolytic systems. The histopathology of hyperacute rejection is manifested by thrombosis, edematous changes, but no pronounced mononuclear cell infiltration. Immunostaining shows shows or has highlighted deposits of immunoglobulin complement component C3 and fibrinogen. Antibody-mediated rejection may also occur without thrombotic occlusion. In this case, the histological pattern is a vasculitis that may lead to necrosis of individual cells of graft blood vessels. Because lymphocytes may also be involved, this process has been referred to as acute vascular rejection. So now in regard to acute renal failure or rejection. So acute renal failure also referred to as acute kidney injury or AKI, is characterized by a decrease in glomerular filtration rate (GFR) experienced over an epoch of hours or days, resulting in the malfunction of renal pathophysiology or physiology to excrete nitrogenous waste or blood or toxins or waste commodities, and maintain fluid fluid electrolyte hemostasis. In this context, there is lots of literature. There's lots of literature in around acute kidney injury or acute renal failure. But in line with this context, rigorous study of acute kidney injury or acute renal failure is complicated by the lack of a sort of uniform based definition, and more than 20 definitions have been published in both basic science and clinical trials. Despite these difficulties, the incidence of acute renal failure varies considerably, subject to the clinical cause and setting. And so, for example, the regularity among recipients has been documented as 1% admission to the hospital, and 2.2 to 5% during hospitalization, and as high as 4 to 15% after cardiopulmonary bypass. For example, as established by works in the mid 90s by Thadani and team, and Albright in the early 2000s. Approximately 30% of patients are recipients who experience acute renal failure and require renal replacement, another form of renal replacement therapy or RRT. Community acquired acute renal failure occurs, has been documented and where it can occur approximately occurs in approximately 200 just over 209 patients to 209 patients per 1 million population, and the frequency of this disease appears to be increasing in hospitalized recipients. Over 60% of the cases of community-acquired acute renal failure are due to perirenal conditions. Frequently, this disorder is initiated by excessive non-replacement fluid deficits due to gastrointestinal, renal, and cutaneous losses. However, hospital-acquired renal failure is primarily due to reduced effective renal perfusion. There's Albright Albright in 2000s highlights some further context or basis in around this in his work, in their works. Post-renal causes account for 5% to 15% of cases of community-acquired acute renal failure. A history of prostatism, urolithiasis, retroperitoneal disease, or use of medications known to cause crystalluria should prompt a thorough evaluation to rule out sort of sense of obstruction. The incidence of renal failure due to vascular disease is or has been increasing, and epidemiological data again have linked and identified and documented sort of aspects in around the aging population and widespread use of vasoconstrictive procedures, which have led to the general increase in the incidence of vascular causes of intrinsic renal failure. The assessment of patients with acute renal failure who have a renal allograft does not differ all that much from that of the general population. Serum, urine, and radiographic studies are indicated, and therapeutic levels of immunosuppression agents should be established at trial laboratory levels. Rejection of the transplant is one of the renal rejection of a transplant is one of the parenchymal can be a cause of can be just one cause of the parenchymal where there can be a cause linked to the parenchymal causes leading to acute renal failure. And again, a review of medication history to determine whether induction of the hepatic metabolic pathways has been stimulated by pharmacotherapy or pharmacological agents, thereby decreasing immunosuppressant agent levels, thereby decreasing immunosuppressant agent levels is and can be necessary, as it is an assessment of compliance with the medication or pharmacotherapy regime as well. Transplant biopsy is frequently performed to determine presence and or extent of rejection process. Acute cellular rejection is mediated by lymphocytes which have become alloactivated against donor transplantation antigens. In vivo stimulation of alloreactive T cells takes place primarily in the peripheral lymphoid tissues of the recipient, although intragraft sensitization may or can occur, and the strongest stimulus is provided by donor dendritic cells, also referred to as passenger leukocytes, in an allograft, which will and can enter the circulation and end up on lymphoid tissues of the recipient. The dendritic cells function as antigen-presenting cells, and they provide a strong stimulus of human leukocyte antigen HLA class II reactive CD4 cells, which then or can stimulate the growth and differentiation of HLA human leukocyte antigens class I reactive CD8 positive cytolytic lymphocytes. Alloreactive lymphocytes enter the circulation, and they will react with they will react and can react with allograft vascular endothelium, the primary target of the initial stage of cellular rejection. The lymphocyte endothelial interactions depend on the expression of appropriate target antigens on the endothelium. HLA class I antigens are constitutively expressed at cell surface area, whereas HLA class II antigens HLA class II antigens expression must be induced by various cytokines, especially gamma interferon. Furthermore, adhesion molecules, so for example ICAM, VCAM, integrins, and selectins may also play an important role in the cell surface interactions between lymphocytes and endothelium cells, and activation and release of cytokines and inflammatory mediators. These processes lead to migration of lymphocytes through a vascular wall. Grafting infiltrating lymphocytes can mediate various effector mechanisms of allograft immunity. Besides a direct cytotoxic effect on graft parenchymal cells, lymphocytes may also mediate a delayed type hypersensitivity mechanism of allograft rejection. The latter involves the recruitment of macrophages and the release of various cytokines. Other inflammatory cells may also be seen during rejection, including neutrophils, eosinophils, B lymphocytes, and natural killer cells or NK cells. Varying proportions of CD4 and CD8 lymphocytes are found in cellular infiltrates of rejecting allografts, and many of them express T cell activation markers like interleukin 2 or IL-2 receptors, and probably through release of gamma interferon and other cytokines. There is an increased expression of HLA antigens, especially class II, on vascular endothelium and other enduring cells in the graft parenchyma. Consideration must be given or should be given to additional immunological mechanisms of graft injury secondary to infection, especially by viruses. This means that other types of lymphocytes may infiltrate the graft or allograft, and they could mediate immune effector responses against virus infected cells in the allograft. Another possibility is the graft infiltrating lymphocytes mediate recurrent is that graft infiltrating lymphocytes can mediate recurrent autoimmune disease processes. Historically, um, uh, although data in and around sort of the etiologies, the etiological basis are still generally have generally been investigated according to different investigations. The most frequent cause of acute renal failure in patients with pre-existing chronic renal failure can be, for example, tubular necrosis, or ATN, and pre-renal failure. And the distribution of causes in and around acute renal failure is in recipients is similar to those observed in patients without any form of chronic kidney disease, or CKD. So, for example, data has retrospectively highlighted that 43% can fall into acute tubular necrosis, 27% can fall into perirenal causes, and there's data that also indicate that 15% had not been recorded in previous investigations, previous sort of epidemiological investigations and studies, and other where 15% where 15% are documented and are not particular or specific. So now okay, and in a line to this, ischemic injury to an allograft from cadaveric donor can lead to delayed graft function, can lead to something that has been referred to in literature as delayed graft function, or DGF, which has been recognized aligned to acute allograft rejection, or AAR, and decreased and where there's decreased allograft survival or prognosis. Extensive local release of cytokines, complement activation, and increased expression of major histocompatibility complex MHC class 1 and 2 molecules occur as a result of renal ischemia. Additionally, at the site of ischemia, local production of tubular necrosis factor, or TNF, and the complement fragment induces the expression of selectins of ICAM1 on endothelial cells. Initial research with antagonists of platelet activating factor and antibodies against ICAM1 have suggested that platelet activation and leukocyte endothelial cell interactions may be crucial in early post-transplant renal failure and rejection mechanisms in humans. And so now I'm going to highlight some context in around chronic renal failure, or CRF, or in context of rejection. So chronic renal failure, or CRF, is perhaps one of the most is almost always an irreversible impairment of renal function, and it is common for a recipient to have trivial symptoms or none until glomerular filtration rate, or GFR, has fallen to 10% of normal. Mild chronic renal failure, or abbreviated as a CRF in literature, historically or retrospectively, is referred to as a chronic renal impairment. CRF is not a diagnosis per se, but a clinical hematological and biochemical bases, which results from progressive or the functional components, uh, um, uh, where there's loss of the functional components, the nephrons, and aligned to renal pathophysiology. In the works, there's works by Gabriel in the late 90s, who have who has highlighted a basis in around the pathophysiology, as well, in and around in around acute renal failure and chronic renal failure. The major complication affecting most long-term transplant survivors is not completely understood. Chronic rejection is characterized by vasculopathy, fibrosis, and a progressive loss of organ function. Its pathogenesis probably involves both humoral and cellular immune mechanisms. Chronic rejection may be mediated by a low-grade persistent delayed type hypersensitivity response in which activated macrophages secrete mesenchymal cell growth factors. Of potential importance are persistent viral infections which induce cellular immune responses that may synergize with donor-specific alloreactive T cells within the allograft. Chronic rejection may also reflect chronic ischemia secondary to injury of blood vessels by antibody or cell-mediated mechanism. Vascular occlusion may occur as a result of both smooth muscle or cell proliferation in the intima of arterial walls. During the earliest days of clinical renal transplantation or transplantation graft, allograft survival rates after 1 year often were documented as often as low as 30%, but improvements in immunosuppression agents matching of MHC or major histocompatibility complex MHC of donors and recipients, and improved patient aspects of patient care have led to sort of better prognoses from that from where there's often allograft prognoses and rates as low as 30%, but where prognoses in that first year of transplantation go from anything from 30% up to 80 or 90%, where prognosis is better. However, this remarkable improvement has not resulted in a corresponding increase in graft in allograft survival. So whilst there may be better advances in aspects of healthcare, or how care is implemented, at the same time, the improvement has not resulted in a corresponding increase in long-term allograft survival. For example, there have been that data in US or United States registry-based data have indicated that although 1 year allograft survival rate for individuals with an initial first renal transplant from a first renal transplant from cadaveric donors performed since 1989 was in the late 80s, early 90s, and 1989 was or had been documented as 82%. Half of these allografts had failed within 8 years, within a decade, and in fact, data has highlighted retrospectively that despite improvements in early allograft survival, the rate of delayed graft function, the rate of delayed DGF or delayed graft loss has not changed, significantly over the past 2 decades. Um, uh, Chronic rejection is poorly understood, and almost certainly involves a number of interrelated factors. One of the most important of these is acute rejection, and several studies have shown that increased rates of acute rejection are closely associated with an increased incidence of delayed graft loss. Thus, and even though acute rejection episodes can be treated successfully, the graft almost certainly sustains some damage, which cannot from which it cannot recover. So now, in context of transplant tolerance, so it was Zay and Weglinski in the late 90s, and specifically 1999, postulate that evidence implicating an integral role of immune regulation in transplant tolerance derives mainly from types of observations. The first tolerance in rat laboratory models or rodent models uh, uh, had been adoptively transferred, had highlighted that adoptively transferred by lymphocytes from long-term survivors into naive secondary test recipients, and second, the maintenance of the transplant. Second, the maintenance of tolerant of the tolerant tolerant of transplant tolerance requires persistence of a donor antigen. Third, cellular infiltrates containing a large proportion of T cells can be frequently found in intolerant allografts. There have been documented cases of graft tolerance in liver allografted recipients and bone marrow renal transplanted allograft recipients. In some such cases, recipients have immunosuppression therapy withdrawn as well. And so in this context, one should acknowledge this is a rare it has been documented as a rare occurrence where immunosuppression is withdrawn, even in where there's been documented cases of graft tolerance between recipient between organ specialties, and aligned to immunological from an immunological basis. Early investigations on the phenotypic characteristics of regulatory T cells in peripheral transplant tolerance indicated that both CD8 positive and CD28 negative T cells restricted by allergenic HLA class 1 antigens and are able to prevent upregulation of B7 molecules by T helper cells on T helper cells or TH cells on antigen presenting cells or APCs. In a miniature swine renal transplant model, laboratory model, host immune regulatory mechanisms contributed, least in part, to peripheral tolerance induced by a short course of cyclosporine immunosuppression treatment or pharmacotherapy, and indeed lymphocytes, possibly CD8 positive cells from tolerant recipients, were able to suppress anti-donor cytotoxic T lymphocyte responses of naive recipient matched lymphocytes. Although the goal of transplantation is to achieve a long acceptance of allograft, little is actually known about the mechanisms responsible of this successful prognoses or outcomes, and several concepts have been forward to explain the immunological basis and tolerance to transplantation to transplantation. One deals with clonal detect one of the concepts has been is around the clonal detection of donor-specific lymphocytes in long-term transplant survivors. This means that rejection-mediating donor-specific alloreactive T cells have selectively been eliminated in these recipients. Another concept is and possibility is that donor-specific T lymphocytes have become anergic, or also referred to as sort of non-reactive, so they cannot function anymore as effector cells mediating allograft rejection. A third concept is that long-term survivors have developed suppressor lymphocytes or soluble suppressor factors which downregulate the donor-specific immune factor responses against an allograft. Relevant to this is the idiotypic network concept, whereby the immune response triggers antibodies and anti-T cells as regulatory mechanisms of the immune in around the immunological response. And the most recent one of the hypotheses retrospectively has been to explain long-term graft acceptance is the persistence in the recipients of donor-derived dendritic cells that promote an immunologically mediated chimeric state, chimeric basis between the recipient and the transplant organ. Regardless of the mechanisms of transplant tolerance, it should be noted that most long-term transplant, long-term allografted recipients or individuals require continuous immunosuppression, pharmacotherapy or pharmacology treatment for pharmacotherapy or treatment. Continuous immunosuppression or pharmacotherapy for maintaining allograft function. Although some notable exceptions have been documented. In the literature. And so now in context of this, controlling the expression in and around a model of antigen specific tolerance. Um, uh, there's So in context of a model of antigen specific tolerance, controlling the expression of this sort of dual IL interleukin T3 and interleukin T4, or IL-T3 and IL-T4, may allow the immune system to tolerate the donor a donor organ, but leave the rest of the immune response but leave the rest of the immunological responsive bases alone, avoiding the risk of infections and malignancies observed with non-specific immunosuppression pharmacotherapy. Immunologists have been searching and exploring for full explanation of T cell tolerance from an immunological basis, at least for the past for over 3 decades, to help improve the acceptance of transplanted organs. Tolerance prevents prevents the immune system from attacking own tissues and harmless foreign antigens. Self-tolerance can be partly explained by the destruction of cell tissues by T cells that react to self antigens, but some self-reactive T cells slip through the destruction process, killing tissue in the body. Convinced an antigen-specific mechanism of tolerance exists, there's works by Secure Foka and colleagues from the University of Washington and in Rome, several years ago, and perhaps longer, where they began looking for and found looking for and also found a different set of T cells, and these T cells, or suppressor T cells, induce tolerance after recognizing the antigens on specific on the surface of another type of immune cell called dendritic cells, where the process present antigens to T cells, other T cells, including T suppressor cells, T helper cells, and T killer cells. Somehow, after this after the recognition, in around the immunological basis, the T suppressor cells sort of robs the dendritic cells' ability to activate T helper and T killer cells to respond to the same antigen, and without active T helper and T killer cells, the immune response to an antigen is put on hold, so to iterate. Looking at research sort of from works by Suafoka and sort of team. Um, Two proteins play a role in vivo. In organ transplantation, the patient's immune system initially reacts against dendritic cells that come from the donated organ. If the dendritic cells or can be suppressed, a patient or a recipient may have a lower risk of rejection. In works by Suka Foka's investigation, retrospectively, 5 out of 6 patients in context of in context of heart transplantation or cardio transplants, cardio transplantation. 5 out of 6 recipients who had T suppressor cells capable of suppressing the donor's dendritic cells. The donor's dendritic cells experienced no acute rejection episodes. 9 other recipients could not suppress the dendritic cells, and all 9 experienced 2 or 3 rejection episodes. In this context, as well, receptor pain may help. Receptor pain may help in transplant tolerance or intolerance. That now draws this particular audio podcast to a close. And this has been an audio podcast aligned to the Ztorm Focus v.3. It's an audio podcast in and around immunology, antigen presentation, and aligned to observing chemokine and chemokine receptor expression in acute renal allograft rejection, or AAR, and it's been another Ztorm Robotics production. Thank you for tuning in.